Watch me dance, dance the night away. My heart could be burning, but you won't see it on my face. Watch me dance, dance the night away.
So if I get thrown out like I did then, do I just do what I did?
When my heart breaks, when my world shakes, I don't play safe. Don't you know about me? I could dance, I could dance, I could dance. Even when the tears stop flowing, like diamonds on my face, I still keep the party going, not one hair out of place. Yes, I can. Even when the tears stop flowing, like diamonds on my face, yes, I can. I still keep the party going, not one hair out of place. Watch me dance, dance the night away. My heart could be burning, but you won't see it on my face. Watch me dance, dance the night away. I'll still keep the party running, not one hair out of place. When my heart breaks, when my world shakes, I don't play safe. Don't you know about me? I could dance, I could dance, I could dance, dance the night.
Right. Welcome, everyone. I think we're going to go ahead and get started, given that we're about 6 after the hour. So thrilled you are all here. My name is Maria Thomas, and I am the Beyond Do No Harm Fellow at Interrupting Criminalization. I'm a light brown skin, South Asian woman with short black curly hair. And if there's ambient sound around me, it's because I'm in a library because Michigan's been having power outages all day. That said, so thrilled to be with you all. And I just wanted to share a little about interrupting criminalization before I share a little bit about what this session will be and hand it over to our facilitator for the day, Aliza Cohen from Drug Policy Alliance. So Interrupting Criminalization is an organization that was co-founded in 2018 by Mariam Kaba and Andrea J. Ritchie to be a movement hub for organizers working across the country to build a world free from surveillance, punishment, prisons, policing, and criminalization. And we know that one primary way that criminalization happens is when people are seeking care. Through access to medical care, to healthcare, we find that people are criminalized in those very places. And so every month we have been organizing sessions with healthcare providers, social workers, and different kinds of public health workers and people within the medical industrial complex who want to interrupt criminalization. And so this is our 6th session, and we are so thrilled to have an incredible group of panelists, and we'll hear from the panel in the first hour. And in the second hour, what happens is we spin off into groups that are based on professions. So we have beautiful facilitators from groups like the Network to Advance Abolitionist Social Work, White Coats for Black Lives, Nurses for Sexual and Reproductive Health. And so they will be facilitating group conversations in those breakout rooms so we can strategize around what we've heard and what are ways that we can all individually in our professions work to build another world where we interrupt criminalization and people can get the affirming care that they need and deserve. And so with that, it is my pleasure to hand it over to Aliza Cohen from the Drug Policy Alliance to take it away for the panel and to kick us off on that discussion. Thank you and welcome again, everyone.
Thank you so much, Maria. As Maria said, my name is Aliza Cohen, and I'm a research coordinator at Drug Policy Alliance. I'm really thrilled to be here today to help organize this session with a stellar team at Interrupting Criminalization and with this really great group of panelists. For those of you who don't know, Drug Policy Alliance is the country's leading organization working to end the war on drugs and build drug policies grounded in science, compassion, health, and human rights. Before I introduce our panelists and jump into the questions for today, I want to offer a bit of framing and grounding for the conversation. We know that punitive drug policies certainly include arrest and incarceration, but they also go beyond and impact systems like housing, education, public benefits, and healthcare. The drug war's deep roots into our everyday lives make us unhealthier and more unsafe. Punishment and denial of services and care for real or even suspected drug use are routine features of our public civil systems. Drug war practices that remove people from society, restrict access to basic necessities, and punish people and separate families result in the very harms that our policies supposedly seek to eliminate. Not having a home, not making a livable wage, and being food insecure, for example, all contribute to increased problematic drug use and increased drug-related harms. We're in a moment where drug use and sales, particularly public drug use and sales, increasingly dominate public conversation and media headlines. I want to frame today's discussion with this. It's imperative that we recognize that, quote, social problems like problematic drug use or addiction occur not because of individual failure, but because of systemic failures like government abandonment and disinvestment, economic insecurity, drug prohibition, and a lack of robust, accessible healthcare. And I ask us all here today to question why our collective instinct in the US is to disappear people to jails, detention centers, and hospitals, rather than create true community-based and driven health and safety. This current moment requires that we turn inward to challenge divisions between people deserving of care and people undeserving of care. We must care about and center the liberation and self-determination of people who use drugs. We can look to drug user unions as groups who already are and have been practicing abolition. People who use drugs have long found safety from each other, not from cops, not from the courts, not from traditional healthcare. Drug users unions and harm reductionists have practiced abolition through demanding that every person who uses drugs is deserving of life, as we saw as far back as the Young Lords takeover of Lincoln Hospital, and as recently as COVID-19 rapid response among networks of people who use drugs. Drug users unions have practiced abolition through asserting demands for bodily autonomy, through distributing syringes and pipes even when it's not legal, through daring to set up overdose prevention sites, through testing and distributing their own drugs, like the Drug User Liberation Front in Canada has done, to ensure that people can have a safer drug supply. And ultimately, people who use drugs have practiced abolition through caring for each other because of and in spite of the drug war. Stigma and political will keep us from safety. It's not that we can't do it another way. So I'm really honored to be joined here today by 5 panelists who have been resisting criminalization and dreaming and demanding different futures. So with that, I'll ask each of our panelists to very briefly introduce themselves. They can introduce their name, where they're calling in from, and their affiliation. So I will start with Louise. Can you introduce yourself, please?
Yes. Can you hear me?
Yes.
Okay, so you just want me to give a general introduction?
Yeah, if you just want to say your name, where you're calling in from,
Yeah.
and affiliation.
All right, so I'm Louise Vincent. I am working with North Carolina Survivors Union. We are out of North Carolina, and I also work on the leadership team of National Survivors Union.
Thank you. Marilyn, can you introduce yourself and where you're calling in from and your affiliation, please?
Hello, my name is Marilyn Reyes. I'm co-director of the Peer Network of New York. And I am calling from the Bronx, New York.
Thank you. Tammy?
Hi, everyone. I'm Tammy Alt, calling from Peoria, Illinois. I am the executive director of GRASP, Broken No More, and the executive director of Jolt Foundation, which is a comprehensive harm reduction program, including syringe exchange in Peoria, Illinois.
Thanks, Tammy. Kim?
Hey everyone, I'm Kim Sue. I'm an addiction medicine doctor. I'm calling in from New Haven, Connecticut. I'm an addiction medicine doctor up at Yale.
Thank you. And Jackie.
Hi, I'm Jackie. I'm a health privacy attorney at Legal Action Center, and I'm calling in today from New York City.
Excellent. Thank you. I see we lost Louise, but hopefully we can get her back. I know we have just a short amount of time for the panel questions. So I'll invite all of you to speak when you want to, but feel free to jump in or pause or stop the conversation. I want this to be dynamic conversation and everyone should feel free to answer whatever questions. So with that, I would offer this first one to Kim and or Tammy. But again, anyone should feel free to jump in. So to start, when a person who uses or has used drugs or is assumed to use or have used drugs shows up at a healthcare facility for any kind of care, whether it's drug related or not, can you walk us through some of the behind the scenes decision trees that medical providers might navigate based on their assumptions or knowledge of someone's drug use? What are some of the overt actions they might take based on these assumptions?
Well, I also forgot to say I'm a OBGYN in private practice, and I focus on, and I'm also a Suboxone provider, and I focus on providing services to pregnant women, but I also have male patients because there's not enough people doing it here. So I had to jump in and serve who I could. There's what we should be doing, and there's what really happens. For sure, pregnant women are the most heavily stigmatized of anyone who uses drugs. And I fought long and hard to, within my local community and everywhere that I can, to try and cut back on that stigmatizing language, attitude that often comes with a woman who shows up who's a person who uses drugs. So usually, everybody, okay, we have to get a drug screen right away. They wonder if they're just trying to get pain pills for something. But we're working very hard to move away from that and just treat the person, treat them there for what's wrong, what their complaints are that day, and speak honestly with them and with kindness and compassion. And not assume that everything is going on because they've used drugs. For instance, they might have high blood pressure because they have preeclampsia. We can't assume, oh, they were just using meth, that's why their blood pressure is high. And so I think in Illinois, or at least where I work, we're doing a really good job at not doing that. But, there's a lot of stigma in the ERs, when someone comes in, they're just trying to get drugs. They're very stigmatized. A lot of our people are also unhoused. They are afraid of medical institutions. They've been treated so poorly throughout their lives that it's difficult to get them to trust us. So I think just building trust, being kind, and treating them like you do every other patient without the stigma is what needs to happen, but doesn't always happen.
Thank you for that, Kim. Yeah, Kim, please jump in.
Thanks. So I'll just jump in and say, from the addiction medicine consult side, I want people to know that I'm coming, and I want to give them privacy and space, and I want to treat their withdrawal and pain immediately. I believe people. I ask for their consent. I tell them in as much detail as they want about any tests that we'll run, and ask for their consent for toxicology, for example. And to echo what Dr. Olt has said many times, I was just thinking about writing a paper with some of the surgeons, because so many of my patients have hand infections, and the plastic surgeons come by on hand surgery and treat my patients like shit, and they're not in a good place physically. They're in withdrawal to really even accurately report a history. There's a lot of assumptions, that substance use is the cause of X condition, and people aren't often not taken seriously. So even just making sure their withdrawal is taken care of and coming back in half an hour, and have some food and have like a nap, like people are so much more engaged, and you can have a much more compassionate place to start. So I think that's where I start. And we know that those are routinely violated in the emergency room. And in fact, for my patients that have to go into the hospital, I coach them on, who's going to be there, who to call. This is my number. I'm going to call in. I organize a very specific thing. And even despite that, they still get treated terribly. And
Yeah.
I go in there and advocate for them because but even if I go in and advocate against everybody, I can sometimes still lose. So it's a very humbling thing to be a part of a healthcare system that does violence and harm to all my patients.
Thanks for that, Kim. Marilyn, I'm wondering if you have anything else you'd like to offer based on your work with Peer Network and what people see when they walk through the doors of any sort of healthcare facility.
Well, my day job, I work in the emergency room, and I get called when someone has a non-fatal overdose. So I'm the one that engages them. I watch how doctors and social workers in the hospital treat the patients. I recently was in tears, right? Because I had this patient that had overdosed, and he kept asking me for his friend. His friend died from the overdose, but I wasn't going to tell the patient that his friend died. I just told him, I'm here just to, work with you so you can feel better. But the doctor, since his oxygen level kept dropping, I kept telling the doctor it could be xylazine, but the doctor would not acknowledge me. Like, she just didn't want to even talk to me. And I kept telling her, so they kept putting naloxone in him and naloxone and naloxone. And I kept telling her, I started handing out fact sheets on xylazine because I was like desperate now, because I'm like, you're going to make this man so sick, he's going to want to leave. And right now he's not in no condition to leave. They wouldn't listen to me.
You get away. Like,
And I went the next day to visit the patient because they had to admit him, and he was on a naloxone drip. I was like, what the fuck? Like, why can't you just read this paper and educate yourself? I'm trying to educate you because I'm the expert here, because I'm in the streets. I know what's going on. But the doctor refused to listen to me. This man was curled up like a fetus by the next day. He looked so bad and I didn't know what to say to him. I was like, I'm not a doctor. I'm not the doctor. I'm just a peer here. But I feel your pain. I'm with you. I tried to get him to eat something to drink, but he wouldn't, and those are sometimes the obstacles and the barriers that I reach, because I'm trying to educate doctors, but because they're doctors, they feel that I can't educate them, or they don't value what I have to say. But I do take moments when it's possible, and I'll take the doctor aside or a nurse aside and just have a conversation. And I've had many changes of minds and hearts that say, oh, I didn't mean to offend the person. But we have that conversation. And I try anytime that I can to educate a nurse or even just a worker in the hospital and say, don't treat them like that. And then I go into language and stigma and judgment. And they get it, and I've seen doctors actually do a turnaround, but it should be more. They should all be doing it. They should be educated. They should be having trainings for them, for people like us.
Thanks so much, Marilyn. So from all of you, I really heard reframing who's deemed as the expert, really democratizing knowledge and expertise, and recognizing patients and people who use drugs as experts and as agents of their own care. I'm sorry, I'm going to slow down. I also heard from y'all the need certainly for more training around drug use in addiction medicine, but also the importance of treating people who use drugs as holistic people, not solely as drug users, but as people with complex needs and full people. So I want to move now and bring in Jackie to the conversation. And Jackie, I want to ask you, what are some of the privacy implications of how someone may be routed through the healthcare system? And how do technology and electronic health records in particular complicate privacy?
Thanks. What a great question. I really like the way the question starts by focusing on how someone gets routed through the healthcare system. And I have a few examples, but before I get into them, I also just want to flag and ask the question about how race and whiteness and racial capitalism also runs through the way that we have different rights to control our health information, depending on where we're getting services and where we're routed through the system. So the first really clear example is if you enter the emergency room for care related to your drug use, or you are a drug user and you need unrelated care, you legally have less privacy rights than if you're seeking substance use disorder treatment from a clinic or an OTP. Under the law, you have less rights. And that's particularly true when it comes to sharing information with law enforcement. So it can be the same information, but depending on the setting that you enter, you'll have different rights to control how the information is shared. The second example is that if you enter the healthcare system on your own, you get a little bit more control of your information than if you're mandated by law enforcement or drug court or criminal legal system. If you're mandated into treatment by a child protective service caseworker, because even if you have those rights under the law, the way those systems work is they require you to sign the rights away as a condition of getting the service. So you have to sign a consent form saying that your treatment program or your mental health counselor can share information. And if you don't, that can be used as evidence in and of itself that you're not compliant, you're not committed to treatment. Signing away your rights in the form of signing this consent form to authorize disclosure is treated as commitment to your treatment, when really in a world of quality treatment, maintaining our civil rights for privacy should be part and parcel of quality treatment, right? Like you actually need privacy rights to get good treatments, that you trust your provider. And the idea that you need to sign them away to show that you're committed is really perverse. And it means that people who are mandated into treatment just have less access to control their information. And then the last and absolutely best privacy protection is to not have your data collected at all. And I think this connects to some of what the other panelists have said about drug testing. If you are getting drug tested as an element of your prenatal care, no matter what privacy law exists, it's worse than if you don't need to get drug tested as an element of your prenatal care. Once that data element exists, it is so easy to slip away. And so if you can go to a clinic where they're not doing long screening for Medicaid to determine your housing and your risk of interfamily violence and your recent drug use, if you can just go to a clinic and get the services you need and leave, sort of regardless of what privacy law applies, you are more protected from a privacy perspective because that data hasn't been collected. The quick thing I'll say about technology, so I don't ramble on too long, is just that technology is letting us create these giant data sets, and over time, so it will be sort of the health version of a lifelong rap sheet, right? So every place that you've received services in the healthcare system, in jail, in prison, through a CPS caseworker, and it's all just getting stacked up there in ways that are not being very well controlled. And so I think technology, I could talk for a long more time about, but is really driving a lot of the harm that we see with unwanted disclosure and sort of unwarranted data collection of particularly of people who use drugs and Black and brown people.
Thank you, Jackie. That was excellent. I think people would be happy to hear you wax on about privacy all day. Louise, I'd love to bring you into the conversation and ask you, with these privacy implications in mind that Jackie just discussed, how do we also have better and more realistic, honest, open conversations between patients who use drugs and with doctors? I'm wondering if in your work at NSU, National Survivors Union, or NCSU, North Carolina Survivors Union, what people have described as effective conversations between patients and providers.
Well, thank you, and I'm sorry for the insane tech problems, but I think we just have to duplicate Dr. Kim. Like, we just need to Xerox her. No, no. I mean, number one, I did not in my own life recognize how important and I'm going to mess it up. It was CR or something. It had to do with methadone, and it kept some privacy around methadone that I didn't understand exactly what the implication was there. And so recently I've been seeing how, one thing affects another. Like, so, and you can't get rid of it. Once it's on there, it says, and that's one doctor that you've had one experience with, and they may not think much of you. And so they may write, they may write something that is now going to follow you around and make, it used to be you could go to a different doctor. You could try somebody else out if something went bad. But now it seems like you can't do that because they'll start with a sort of pre-existing understanding of who you are. And I'm afraid that some of the, some of the things that, like, if you're mentally ill or bipolar, some of the things that or depressed, like some of the things that happen, like, people don't understand that, like, depression is not just like, oh, I'm so sad. Like, it plays out in these ways. And I really, we are working in North Carolina to train the Duke doctors. And what a disaster that's been. We were only trying to share with them about implicit bias, right? But they have so much bias that they can't and won't see it. And actually asked me, can we get a doctor to deliver some of this information? And then I said, well, we work with some doctors, and they said, do you know the difference between a MP, like a PhD and a MD? So that's the kind of, but yet they claim they have no bias. Having these conversations with doctors is challenging. Having these conversations with doctors when I'm out in the field doing work as just me, like, is challenging. So, like, when I'm trying to get medical care, so from, there's two different ways to look at it. You have your personal experience, and then you have, like, what happens to society and the group. And I'm telling you, what they say is they're doing this stuff for our safety, right? We're just trying to keep you safe. So we're going to limit your mobility. We're going to do these things that we call, safe. Like, we want you to be safe here. And really limiting someone's mobility and doing some of these things without someone understanding what's happening is really a disaster, and continues to build, continues to build this crisis we have, where I have not had somebody walk into our syringe service program in the last, bit, like at least 6 months, that has had a positive experience at the hospital. And just as an example, real quick, so one of the people I know had a tick bite, and they went to the emergency room over this tick bite. It was getting really bad. And, she's telling me about it while we're standing there. She doesn't say anything bad happened at the hospital. And I said, how was your experience at the hospital? Because I thought maybe it was good. And I just watched tears welt up in her eyes. There it was. They had given her buprenorphine on top of her methadone. and said, this is what they gave people. I mean, this is at a medical center, and threw her, and they said, well, if you go into withdrawal, we'll just get you out, which is impossible. Yeah, they said, we can reverse it if it goes bad, which was not true. I mean, these stories go on for forever. And I think we need to think about privacy and what that actually means. And we need to think about, like, I really liked what you said about the lifelong rap sheet. Like, that is so, like, I feel like our medical system has become a police state sort of system. Like, you know what I mean? Like, if you don't do what we say, we're just gonna mandate you to this bed. We're just gonna get in there and we're gonna take your kids. We're gonna do these awful things. And, you know, it was like my methadone doctor was asking about, like, did I follow up on my appointments over here? Like, what are you talking about? Like we have a system that I recognize their desire to be helpful, but at the end of the day, like, they're not getting it, and they're not willing to listen to anybody. And that's why I say we have to like Xerox copy Kim too. Like, because I don't know how we teach people something that are so closed to learning from people like myself and Marilyn.
I want to share my story about my doctor, right? I have a doctor that I've had for many, many, many years, and he knows my history, right? So in around 2001, no, right before 2001, I got hit by a car. So I was injured and I had to do physical therapy. I had to get on pain medication, muscle relaxers, and he was giving me painkillers like for the last, after that, for about 2.5, 3 years, right? So one day he decided that it was time, because too many people are overdosing, and it was time for me to give up painkillers. So he wasn't going to prescribe me none. So I turned to him and I said, and you're just going to cut me off like that? That's why people die. So I just went in on him, and we went back and forth. But he's been my doctor a very long time, over 20 something years. So he turned to me and he says, okay. So he gave me the painkillers, and then I just started educating him. He one day asked me for a Narcan kit so he could carry it in his car. So, you know, I'm very boisterous and I'm very, like, I'll fight back. But he gave it to me, and then when I was ready, I told him, oh, you can start cutting me down now, because I'm starting to feel much better. And the physical therapy was working after some time. I still get a little back pain, but it ain't what it used to be. So I'm grateful for that. But when I went in, I told him, just give me 1 a day instead of 4 a day. And I just started cutting myself down. And then I told him, okay, I'm done. And he just looked at me and he just shook and laughed, because he was like, I fight him so much. I said, well, I mean, I was trying to get my point across and you wasn't trying to hear me. So I had to voice my opinion, you know. But I wish more doctors would be more open-minded. I mean, like Louise said, yeah, I love Dr. Kim. Like, I'll call her just to ask her a question if I have to, you know, like, and she responds with love, compassion, you know. She always been there. And I respect that. I respect her so much. And I admire her so much. But yeah, if doctors could be just like Dr. Kim, we'd be all right.
That's great. I'm loving this Kim Love Fest here. Marilyn and Louise, thanks so much for that. I think you offered a really vital perspective on the benefit of a positive, therapeutic, trusting relationship between doctors and patients, and also the detriment of what an adversarial relationship can do. So Tammy, Kim, and Jackie, I'd like to bring you guys back in and sort of zoom out for a bit and look at the systems level. So we know that we want holistic, comprehensive care for people who use drugs. But of course, as has been mentioned, we know that there can be privacy consequences when providers are in contact with other agencies. So what are some of the ways that healthcare providers are in regular contact with other systems like probation and parole, like law enforcement, family policing, or child welfare, or treatment providers? And what are the implications, both positive and negative, of communication between different agencies?
Well, I'm not really in contact with those people. So, I mean, they don't contact me about anything. The only time law enforcement I have to get in contact with when I have to fight for my patients who are becoming incarcerated and they won't give them their Suboxone. So I have to call the jail, tell them, you know, this is negligence, this is against human rights, and make all sorts of threats, and then they'll finally give them their Suboxone. Or I had to call a state prison and advocate for a patient to get her Suboxone. But I always tell my patients, because they're all, well, a lot of them have, you know, charges and stuff they're still trying to deal with, even though they're in treatment. You know, I say, you know what, you need me to show up at court and tell them how you're doing? I will be there. You need me to write a letter? I will be there. Because they, you know, some of my patients don't have anybody to stick up for them, and they just end up taking charges, taking pleas, and then they're incarcerated, and then they're not getting any treatment, and it's awful. It's just the most brutal system. And these are charges like not hurting anyone, possession charges, which are felony charges that ruin your life. So I'm just all I do is advocate. Or if law enforcement officers are in the room with me with the patient, you know, a pregnant patient, you know, handcuffed to a bed, which is fantastic. I try and be very vocal about what we're doing, how good the medicine is. I'm kind of trying to convert over the law enforcement officers when they see how I treat patients, because I want them to come along and understand this is a good thing, not a bad thing.
I kick out any cop in the hospital in my room. They do not, like, they cannot be a part of my conversation at all. That's the first thing. Second thing is, I always fighting the carceral system. You have to be super aware of, you know, how to keep your patients out, how to chart. You have to, no one contacts me unless the patient wants, has signed. Or one time the patient asked me to call their PO to report, and that she's like, I'm going to violate her. And I was like, absolutely not. She's like she's in treatment, you know what I mean? Like, and she's like, fine, tell her to show up, or, and we called from my office. So only if, like, we are, in certain circumstances, really, I'm really trying to fight their charges and to prove that they're getting the best care, they're getting evidence-based care, and in the community. And again, the collateral consequences of going to jail or prison can be deadly, and people can suffer. And so I try very hard for people that are, I try to focus on the individual, not necessarily, their context. And, if they have, if they're pregnant, or, I don't really, I want to focus on them and their substance use. And so I keep most of my interview and my notes on them and how they're doing. We do know that so many people, and when I was in New York, I would write medical cannabis, right? So people didn't get, like, their kids taken away. Like, anything that we could do to, like, keep people out of these systems that we know cause so much harm as part of this interrupting criminalization has shown. So anything that we could do, and that also includes advocacy. So I'll take court cases for people in New Jersey. I took a court case for someone who was charged with abuse for taking Suboxone because they toxed the infant. I'm like, she started treatment in the second or third trimester. Like, she's doing everything right, and you charged her. So I'll take those cases because again, like I'm trying to interrupt that cycle.
Thank
It's a
you.
horrible cycle.
Jackie, I want to bring you in, but Kim, I just want to flag this question in the chat for you, which is how do you phrase the demand for cops to leave the room?
I think maybe some of the paperwork that was given, or the PDF that was given on police and the ED can tell you some of the phrases, but I say like, can you please leave the room? I'm doing a private interview with my patient, and they have to leave. At least in Connecticut, I've never had anybody say that they have to stay there. And I say if it's for my safety, I'm going to call another person from the medical team to be present. So it'll be 2 people here and not you.
I've had them resist me that they would, some guys. And this was a patient who was like 1 day post-op C-section. And I mean, I had to tell him, you need to get out. I have to examine this patient. You cannot, but he gave me crap. He finally went out in the hallway, but I'm like, really, where's she going? I mean, it's brutal with the cops. It really is. But we have to stand up for our patients. Like Dr. Sue said, no matter what, we have to be there for them, be their advocates.
Thanks for that. Jackie, anything to add to this conversation around communication between healthcare and other agencies, presence of law enforcement?
Yeah, so I want to say that the privacy issues I was flagging earlier about electronic health records is undermining patients, and it's also undermining providers, right? We have 2 amazing providers on this call. They're not sharing information that they don't have to, but they're putting notes presumably into the electronic health record, right? Which is a health document, but it's also a legal document. It's used to shield from liability. It's a billing document. And so even if the provider is committed to not sharing the information, if the records department gets a subpoena from law enforcement, they will release the records because it is a legally binding subpoena and they have no reason not to, right? If I've been working with a man who has been in an opioid treatment program for a long time. He got a new counselor, and the new counselor reviewed the old counselor's notes, saw that he had custody of his child, saw a positive talk screen, and decided that those 2 pieces of information alone, with no intervening evidence of neglect or harm to the child, warranted a mandated report, and he ended up losing custody of his kid. But the initial provider, they were putting that information in as part of the health record, right? So like the massive amounts of data being collected are being collected for health purposes and then used by systems and for systems that do not have the patient's like wellness or really the patient provider relationship top of mind. So
yeah, thank you. Okay, so thanks for that, Jackie. That's a really excellent segue into one of our last questions, and into a question from Valerie in the chat, which is, would love more guidance from you all on how to document in medical records in ways that minimize unwanted scrutiny for patients. So I'm wondering if any of the providers on the line are also Marilyn or Louise, how you've seen people navigate tension between what is perhaps required by state or federal law, or what is programmatic or hospital policy, and what you know is ethical care. So how have you sort of walked that line in ways that you found effective?
Can you clarify if you want to hear what's coming from a patient perspective or a provider perspective or both?
Both. Happy to hear from you.
I'll just, Louise, while you think, I'm just going to pop in because I did mention documentation.
Right.
So I don't document, I do not document people's charges. I thinking about the medical record as this big document that goes on forever, that's copied forward, that's used, like the lawyer said, in all of these contexts that are not non-medical. I'm very judicious about, I do not document anything. I use, we know that those things carry forward. I don't care if your offense is violent or non-violent. I don't want it in the record. I don't want the record that you assaulted someone or I do not care why, like that is not relevant to my clinical decision making. And so, we might have a conversation about that. But understanding the way in which these things are used against people. So those are, so like I don't document people's charges. I really, try to keep what is relevant to clinical decision making at the moment in the note. And I use very specific clinical language that's non-stigmatizing and that's appropriate. I think about all of my notes as potentially going to court and document, risks and benefits. And I've never, knock on wood, had issues. And I don't want there to be issues for my patients who are often in really, like Dr. Old also has patients, a lot of patients who use drugs have charges and have a whole variety of situations, some of which we can address in the clinic and many of which we can't. So if I can just get you the medication you need or get you the dose you need, or I can do some advocacy, but that can be outside of your chart too. I can write letters and stuff that's outside of your chart or outside of your actual note. So I sometimes do that. And, like I said, I'll do, I spend a lot of time trying to keep people out of mandated, programs or treatment or going to jail or things like that. So I think it comes with, and we can talk about more specific questions, about documentation you can follow up with me.
Thank you. That really helped me sort of frame what I was thinking. And this is from an individual sort of level patient perspective here. Years ago, after I was in a car accident, and that is what caused, and I was left outside for a very long time and all these things. And ultimately that landed in my having an amputation. So I am now an amputee with the upper leg, so I went to the Duke Pain Clinic, and this was years ago, maybe 10 years ago. And the doctor, they said, we have one surgery that might help you, but you've got to get your pain treated through the pain clinic if we're going to do it. And of course, I'd like to save my leg, so I'm willing to do whatever. I get to the pain clinic, and what they tell me is they have pulled my criminal record. And unbelievable. I don't even tell this story sometimes because it's so bizarre. You don't expect to go to the doctor and your rap sheet be there, with my face all picked off, the worst mugshot you could ever take of me. I look like I've been skidded across the pavement. It's not a beautiful, it's not a beautiful Louise. And that's on purpose, I guess. But how devastating. I was just I know, they're what are you even doing here? We can't give you any pain medicine. And at that point, I just break down into tears. You're basically telling me because I don't check a box. I'm too complicated. I've got too many things going on. It would be too much work for us to work with you, Louise. Because you are a complicated mess is what you are. And in order to take you on, I'd have to spend time. I'd have to really like you, and I'm not always that likable when I'm facing leg loss or when I'm facing wounds that are difficult to cope with or whatever I'm facing. It's hard to be the upbeat, hey, doctor, that's not who I am in that moment. In that moment, I'm working to hold it together. I'm trying just not to jump out a window, or do something dramatic, because I don't have the support in that moment you know, and then when you tell people the story, they're like, are you sure, Louise? You know, that doesn't seem like something that could happen. Well, it did, you know, like, and we got to start believing folks, man. We look at these things like they're like one-offs. Okay, well, that happened to Louise, and she's crazy, and you know, all kind of crazy shit happens to Louise. She's got a story for everything. You're damn right I do. I've been dealing with the medical system since I was born, and I've been losing it since I've been dealing with a substance use diagnosis since I was 13, and a bipolar diagnosis, and a mental illness, and conduct disorder, and all of that good stuff. And they tried to work it out at like wilderness camps. We tried to pray it away. We tried to do all these things to get it. We punished me. We beat me. You name it, we've tried it. We got to do better, man. We got to do better. Like, they give people that use drugs, the doctors that are the least able, and the counselors that are the least able, the people that are the least able to handle like all of I'm sorry, my brain, like all of the difficult and you know, just all of the things that make us kind of difficult to treat. Like, it's not just one thing. It's not just I ate too much, you know, or I have diabetes or this or that. It's that I have this affects that affects that. We don't want to give you that because you're a known addict. And so we don't want to treat your anxiety or your PTSD or any of these things, you know, and if we did start to do that, you don't have the insurance to pay for it anyway. So you don't get the ketamine treatment. You don't get all of the good stuff because, you know, you don't deserve it. And you'll probably just, you know, and you're probably going to mess up your medical care anyway. We'll probably have to cut your leg off at the end of the day. So let's just go ahead and make it happen. And that's sort of the attitude that I felt was like conveyed to me a million times over. And, you know, I don't think I'm ever gonna live down what's in this electronic medical record. I'd like to I'd like to see all of it. You know what I mean? Like, I'd like to have access to all the documents so I can at least see what these doctors are looking at before they are making decisions about me. I'm sure it's rich. One other thing, there's IVD policy at many hospitals. So like injection drug user policy. Like, so if you're known to inject dope, like at the Asheville hospital, they take your clothes, they take everything that you have, they put a camera on you. You're allowed no access to the outside world at all. Not even clergy. Clergy is not even allowed to see you here. Like, this is the policy. Like, so knowing that if you live there and you're like, okay, well, I've got this thing growing out of my arm, I really need to seek care, but you know that the policy is going to put you in there and all but kill you another way. I can't be okay under those circumstances. Like, I can't be punished when I'm trying to seek help. Like, it's too painful. It's too painful. And I'm not trying to be dramatic here, but the truth of the matter is, it is life or death. It is our lives. And like, these people watch it play out in real time and they don't find sympathy. What they find is, you know, somebody that deserves to be mistreated. And that's just not the case. Like, because the people that I know that need this assistance, like, are really fucking excellent people. And with a little bit of help and connection to like prevention and things like that, like, and just a little, you know, when people come into the syringe service program that we operate, they are so happy for just the little bit we give. It almost makes me mad that they're so happy about such a crumb. You know,
Yeah.
we don't want much.
Thank you so much, Louise, for that, for sharing and for that testimony. We're about at the hour. So we're about to go to a break, and I want to just sit for like 30 seconds, just sit with what Louise shared and what has been shared over the past hour. And while we're doing that, I'll ask all of our panelists to just think of a sentence or two as we go into this next session, these breakout sessions, about what a true system of care would look like for people who use drugs. It can be an adjective, it can be a feeling, it can be a food, whatever you want. Marilyn, could I invite you in first? I see that you're off mute.
With the word?
Word, sentence. Any other final thoughts?
Well, I mean, they say people that use drugs don't care about themselves, but that's not true. It's because of these policies and these systems that are that just stigmatizes and judges and don't give us that real compassionate dignity, love that we need.
Thank you. Tammy.
Some of you who know me know this already, but what I didn't share was that my 16-year-old son, Josh, died from a heroin overdose in 2012. And when I'm treating people who use drugs, I picture Josh, how I would want him, how I would want me as his mom to be treated. What would I want for my own family? And which is how I try and treat all my patients, but especially with my people who use drugs. How would I have wanted my son to be treated? What kind of care would have I expected for him? And that keeps me grounded and compassionate. And I don't know, it keeps me going every day with everything I do. I just like everybody, I always say everybody's somebody's Josh. So that's my way of dealing with patients.
Thank you. Jackie, could I invite you in?
Sure. So what should our care system look like for everyone who uses drugs? I was imagining like a big banquet hall with a nice buffet, lots of different options, or you can just come and sit down and watch other people eat what they need and take your time, and there would be no video cameras in this buffet hall. It would be, on your own terms.
Thank you. Kim?
I spent a lot of time thinking about this vision. Just a one-stop shop where people are treated like the experts that they are, where they can get all their needs met in one place. In like someone fund me that to do that. And housing, and just like have their needs met and be treated with dignity and respect, and their expertise valued. And we work in partnership, not with all of the terrible things that you've heard from Marilyn and Louise. And that's not prison and jail. That's all. It just seems like such a hard but beautiful thing. So that's what I always think about in the work that I do, and try to push towards that future.
Thanks, Kim. And Louise, any final thoughts on what a vision of care would look like?
I just came up with a word, and that word is connection. Like the more we're connected, and the more, and that's connected, the more we're connected to anything, the more chance we are able to do something. I'm connected to Kim Sue, and I can ask her a question that it improves my condition considerably. because I have somebody to talk to. If I was when we allow this tough love bullshit to continue and like we support stuff like that, we're killing people. We're absolutely killing people because connection, I believe it's like we start disconnecting people like immediately as soon as we know they have a substance use disorder. We're going to take you away from your friends, your family, anything we can. And what we really need is to like pack on the connection and the support and find, if I can't talk to you, then I need to be able to talk to you. Like, I think one of the things that's really difficult is like sometimes our egos get in the way and we don't want people to know. We think we're in the closet about this or that. And like we see what happens when these things, when this stuff goes down, people die because they're trying to hide, this part of their self. It's not morally bad. It's just like, I don't know what it is. It's just part of like it's part of what that person has to experience. I know we need to do better. And like, I think moving toward connection is like an easy way to talk about, like, it's a simple thing for people that like simple, like, what do we do? Connect.
Oh, it's so simple, Louise. Thanks to all of you for sharing those visions. I'm going to hand it over to Maria, but first I want to extend deep gratitude to our panelists for sharing your expertise and experience today. It's always great to hear from you and share space with you all. And thank you as well to our access and behind the scenes team who helped make this event more accessible and helped it run smoothly. That I'll pass it to Maria.
Thank you, Eliza, and just thank you so much. The deepest of gratitude to all of the panelists for your open sharing, your invitations, your vulnerability, and just how inspiring each of you are, and the very direct calls to action. We're going to take an 8-minute break, so do what you need to do, but please do come back so we can actually strategize around what we do with this information, how we're going to make it real. We have folks from Nurses for Sexual and Reproductive Health. We've got a social worker breakout, we've got a public health breakout, and we've also got a physician breakout. So please come back. And just gratitude also to Dario and Taylor for holding down ASL and making this space accessible, and to Esther for providing closed captioning. We'll see you back at 15 after the hour.
If I told you I got caught up in a wave, almost gave it away, would you hear me out? If I told you I was terrified for days.